Welcome to the Health for the World Medicine Grand Rounds. Today we have Dr. Jahangiri, who's trained in hematology and oncology, giving us a presentation about anemias. My name is Anne Catherine Gertler, and I'm a second-year medical student at Wayne State School of Medicine in Detroit. I will be moderating the webinar today. Feel free to put any questions that you have into the Q&A box at the bottom of your screen, and we'll answer them at the end of the session. Go ahead.
Good morning. As Anne Catherine said, I'm Sudy Jahangiri. I'm a practicing hematologist and oncologist in Grand Junction, Colorado in the United States. And I'll be speaking with you guys today about anemia. It's kind of a broad topic. So we're going to start initially with talking just about common labs that we review in the setting of anemia, discuss a general diagnostic approach to outpatient adult anemias, and the focus really will be adult. I don't do any pediatrics, so we won't be touching on that. And primarily outpatient management, although there is some overlap with inpatient issues as well. And then we're going to review some of the common causes of anemia and management of those common causes. That'll include iron deficiency, B12 folate acid deficiencies, anemia of chronic inflammation, and hemolytic anemias. So first, just to review the CBC, that's usually the first lab that's confirming whether or not somebody is anemic. The red blood cell count is one of the first values that is reported. It's not one that we really use much in general practice, but that looks at the number of red blood cells that are present in a set volume of whole blood. The hemoglobin and hematocrit we use a little bit more in identifying the degree of anemia that's present. And it's important to distinguish the difference between those two. Most hematologists, including myself, will use the hemoglobin preferentially. It is a measured value and it looks at the concentration of hemoglobin in a set volume of whole blood. The hematocrit, on the other hand, is more of a calculated value, so it's more impacted by fluid status and a little bit more variable and less accurate than that hemoglobin. It takes the percentage of blood volume that's occupied by RBCs, and the way they calculate that is the red blood cell count multiplied by the mean corpuscular volume, which is the size of those red blood cells, and divides by 10. Because of that variability, we do usually prefer the hemoglobin as a true measure of oxygen carrying capacity. The mean corpuscular volume that we mentioned is this average size of red blood cells. It is an average, so sometimes if you have really small red blood cells and really big ones, you may get a normal size on that MCV. So another number that I didn't write down here, but that's also important to just take an eye at, is the red blood cell distribution width, or the RDW, because that'll let you know if there's a wide distribution of widths, that you may have really big ones and then really small ones as well, versus the MCV that is more of that average. The MCV historically has been how we've divided up anemias. I think in most med schools, that's still how we teach it, is microcytic being too small, less than 80 typically, normocytic between 80 and 100, and then macrocytic are those red blood cells greater than 100. And it does help you to narrow down the cause of anemias, although these are not strict cutoffs, and there's a lot of overlap between the three categories. Reticulocytes look at young red blood cells, and these can be measured as either a percentage or an absolute count. Both give you kind of different types of information. Normal is about 1 to 2% for the percentage, and 0.25 to 1 times 10 to the 11th if we're looking at absolute numbers. This can and should increase in the setting of anemia. So if there's adequate building blocks and adequate bone marrow function, then this should increase in the setting of anemia, and can increase up to 4 to 5%. Other labs that can be helpful depending on the setting, erythropoietin is a hormone made by the kidneys that then goes to the bone marrow to stimulate production of red blood cells. So this can provide us some information as to whether or not the kidneys are doing their part in this process during anemia, and also if that erythropoietin is elevated, then is our bone marrow responding appropriately to create those reticulocytes. The CMP that looks at kidney function, liver function, also lets us know a little bit about protein levels and electrolytes, and all of those can kind of vary your decision making or your workup in different ways and give you a guide as to what's the cause of anemia. For example, if you saw some renal dysfunction, elevated calcium, high total protein, you may be leaning more towards some of those monoclonal gammopathies and may want to do some testing for those. And that's included here on the right. That would be like a protein electrophoresis, immunofixation, serum-free light chain assays, 24-hour UPAPs, those kinds of tests. Hypothyroidism and hypotestosteronism can also cause anemia, so important to check for those in the right clinical settings. LDH, haptoglobin, and Coombs test or direct antibody testing is helpful if there's a hemolytic anemia going on. That LDH will also be elevated in the setting of some hematologic disorders and malignancies. And then a peripheral smear is always our favorite test to be looking at. We'll go over a few examples of those later on in the slide, but that can give you some hints as to what the underlying cause is as well. So our general approach to anemia, for a hematologist, we're kind of looking a little bit more broadly. As I mentioned, sometimes we separate them into that micro, macro, and normocytic anemias. But we also just want to look at the picture of the patient and see, is there anything really obvious that's causing anemia that we may want to tackle first? Obviously, if somebody's bleeding, hemorrhaging, has a history of really severe heavy menses, somebody who's pregnant, we may have an obvious cause right there. Not to say we shouldn't work up other causes, but we don't have to look too hard for that more obvious one. Liver disease and cirrhosis can contribute to anemia. Obviously, someone with a malignancy or anti-neoplastic therapy is going to potentially have some anemia. Any kind of gastric surgery, including gastric bypass, sleeves, those kinds of things, can also impact absorption of nutrients and cause anemia. Dietary restrictions and deficiencies, whether that's through a really restricted diet or just access to those nutrients, can also contribute. And then autoimmune or rheumatologic disease can sometimes cause an autoimmune anemia as well. And then just any other symptom that may kind of point you in one way or another is somebody who maybe has these symptoms or other signs that may make you think that they have an undiagnosed malignancy. The chronicity of anemia can also be helpful, especially in certain ethnic backgrounds. There's more of a propensity for some of the familial hemoglobinopathies, so that is more prominent in African, East Asian, Asian Mediterranean, South American countries, where we're seeing more of the things like thalassemias and things like that. So just something to keep in mind, that family history. And if somebody's been anemic all of their life, it's probably not something new that's occurring. Medication and food triggers are also important on that same area, because G6PD deficiency, which is also a hereditary hemoglobinopathy, that can be triggered by oxidating medications, flavavines, and there may be some family history there as well. Medications are always important to look at. If somebody just recently got some amoxicillin for some infection and then a week later developed an anemia, then we're more concerned about autoimmune hemolytic anemia related to that medication. Proton pump inhibitors can cause some absorption issues with different nutrients, and obviously anti-neoplastics or other medications, anything that it impacts folate, processing, even things like low-dose methotrexate that's being used for rheumatologic conditions can contribute to anemia. As we mentioned, the mean cell volume or the mean corpuscular volume, that size of the red blood cells, can also be helped to further narrow down the cause. Looking at reticulocytes, is the bone marrow responding appropriately? Does it have the building blocks to do that? Is another number that's helpful to guide that cause of anemia. And then whether or not other cytopenias are present. So if we do see that with pancytopenia, there are multiple things that could be causing that. Of course, high on everyone's concern is whether or not there's an underlying malignancy. And there are other things though too, aplastic anemias, paroxysmal nocturnal hematuria, drug effect too, and that can be antibiotics as well as other medications, toxins that cause a suppressive effect on the bone marrow, and viral infections too. With those last three, it's really important to be able to identify that cause. Usually once we withdraw that offending agent, patients will recover. So I know I said the traditional way is to break up anemias into those different sizes, and I'm going to follow that tradition and just kind of give us a breakdown of what common micro, macro, and normocytic anemias look like. For microcytic anemias, commonly we think of iron deficiency, thalassemias, or other hemoglobinopathies falling into that realm, and anemia of chronic inflammation. And there is some overlap of that into that normocytic category. The picture here of our peripheral smear that we're showing you just shows a classic finding that you can see in thalassemias. It's not specific to thalassemias, as it can be present in other conditions. Even things like alcohol use chronically can cause these target cells that you're seeing, the arrows pointing over there. A typical red blood cell should be a biconcave disc. So it should kind of look like a donut where you have a red area around and an area of central pallor. And even though I use the donut analogy, it's not actually a hole, it's just a very thin membrane in that area. And in the setting of a thalassemia, it actually looks more like a hat, if you think of it that way. So the thin area around is as kind of the where the brim of the hat meets that central part, and then you're seeing a little clumping of hemoglobin in that middle area. Macrocytic anemias can be caused by B12, folate, and copper deficiencies. Also, many medications can cause macrocytic anemias. Liver disease, alcohol use tend to cause more of a macrocytosis, hypothyroidism, as well as many hematologic disorders. Normocytic's kind of your grab bag, because everything that causes macro or microcytic anemia can also cause normocytic anemias. In addition to that, androgen deficiency, so that testosterone deficiency tends to be normocytic. Hemolysis usually tends to be normocytic, although sometimes if there's a severe reticulocytosis, reticulocytes are larger than the average red blood cell, so that may skew you a little bit more macrocytic. And then, of course, all of the hematologic disorders can also fall in the normocytic category. I want to spend some time talking about iron deficiency anemia. It is the most common cause of anemia worldwide. The graphic on your right, which I have borrowed, is kind of shows you the incidence of iron deficiency in green across many countries throughout the world. And you can see in most of the countries, it is the most common cause of anemia. And it's also important to note that iron deficiency can be present without anemia being present. Iron is usually taken in and acidified in the stomach and then absorbed in the duodenum. It does require that acidification for best absorption. So anything that either impacts acidification or impacts the stomach or that upper small bowel area can impact iron absorption and cause iron deficiency anemia. Symptoms of iron deficiency are going to include anemia symptoms, things like fatigue, exercise intolerance, dyspnea on exertion, chest pain, lightheadedness, dizziness, or orthostatic hypotension, as well as some symptoms that are unique to iron deficiency. Pica is one of those that we'll always see on those board questions, and that's the eating of non-food materials. So that can be, I think traditionally on our boards, it tends to be ice, but also can be things like clay, dirt, paper products. Typically, it's whatever is kind of culturally appropriate wherever this anemia is happening. And it's pretty specific to iron deficiency. If you see that, you should have a high suspicion. Even in the absence of anemia, you can have these symptoms. Restless leg syndrome is another thing that can happen with iron deficiency. That's less sensitive and specific than the pica symptoms are, but also something to keep in mind if you're working up someone for restless leg to make sure you're checking for iron as well. Laboratory-wise, in iron deficiency, you will see, or you can see anemia if it's progressed to the point where it's impacting that hemoglobin and hematocrit and making those decrease. Can also see the microcytosis. Don't have to see it though, so it's not a requirement for diagnosis. And sometimes you can see platelets being elevated as well. They can be elevated both as an acute phase reactant and just because of the iron deficiency. The peripheral smear on the right shows us just an example of what a slide might look like. These red blood cells compared to the ones that we saw previously are a lot lighter in color. That area of central pallor is also larger, and that's pretty typical. These cells are smaller than the average red blood cell. It's hard to know that. Usually we use our white blood cells as our determinant of what size is, and unfortunately this picture doesn't have any of those in it. We also check iron studies, of course, to confirm the status of iron. And usually I'm checking 4 different tests. 3 of those are these iron studies looking at serum iron, total iron binding capacity, and percent saturation. And then also checking the ferritin, which we'll go over on the next slide. The serum iron looks at free iron that's not bound, and iron can fluctuate pretty significantly by time of day, by dietary intake. So although we check this test, it's definitely not the most accurate to let us know the iron status for a patient. It typically should be low in iron deficiency, but you can also see a decrease in anemia of chronic inflammation and other conditions. And again, if somebody is just maybe been fasting, it may artificially be low, or if they just had a hamburger, maybe it'll be artificially elevated, so not necessarily the best measure. The total iron binding capacity, or transferrin, looks at the molecules that are put out to bind iron. And in the setting of iron deficiency, your body's trying to grab more iron from that GI tract. So it's going to be putting out more of the transferrin. So the iron binding capacity, or transferrin, should increase in that setting. And then the percent saturation is a calculated value that takes the serum iron and divides it by the transferrin. This is typically low in iron deficiency. The last test for checking iron stores is the ferritin, and that really looks more than at what's in the blood, but what's actually in the body, and gives us a better idea of iron stores. It's the first thing that will decrease prior to patients actually developing anemia. So in some of my chronic iron deficiency anemia patients, once we've got them repleted, the ferritin is one of the big tests that I'm monitoring long-term to make sure we maintain their iron status and avoid developing anemia again. Normal values do vary somewhat by lab, but our body has no natural way of getting rid of iron, so ferritin should increase over time and with age. I've had some hematologists who say it should be about roughly a patient's age. I use 40 as my cutoff, depending on who you talk to. Some people go a little lower as 30, some people go a little higher at 50, but 40 is kind of where I fall in the middle. And anybody who has a ferritin less than 40, I typically consider iron deficient. It is important to remember that ferritin is an acute phase reactant, and as such will go up in the setting of any type of inflammation and significant stressor. So if it's below 40 and you have an inflammatory process going on, it's probably actually much lower than that, the patient's degree of iron deficiency. And if it's elevated in the setting of inflammation, your patient can still be iron deficient. That's where looking at all of those iron studies as a bundle and looking at kind of the big picture of your patient is going to be important. So just to review what those iron studies look like in the typical scenario without anything confusing it, serum iron will be low, iron binding capacity should be elevated, percent saturation will be decreased, and ferritin will also be decreased. So as I mentioned, iron deficiency is never normal, and there's no natural way our body has to lose iron other than regular menstrual cycles. And just to put it in perspective, normal menstrual cycles should not cause iron deficiency. Our average female has 4 to 5 grams of iron stores, and the average male has 8 to 10 grams. An average menstrual cycle causes 1 milligram a day of iron loss. So that's 7 grams per month if you consider a week-long menstrual cycle, and then times 12 months is still less than 100 milligrams. 100 milligrams just being a fraction of a gram. So over a year of normal menstrual cycles, a woman should not become iron deficient. So if you are not able to find any other underlying etiology for that iron deficiency in a female, we've got to think that this menstrual cycle is not normal. Maybe there's fibroids, maybe she has menorrhagia that we need to manage with some hormonal method or some other thing. So I think it's just important not to just blame it on that and not to pursue further workup. So our approach to iron deficiency, I also want to stress that, again, always has a cause, and we always need to find that. The other place where I see it just kind of blamed on something and ignored is in the setting of hemorrhoids. I've seen many patients, unfortunately, doing a lot of GI oncology where rectal bleeding has been present for a few years, and they've had some iron deficiency intermittently repleted, and then they may get to me with a metastatic rectal cancer just because we haven't done that workup, because maybe they were 35 and we just didn't really think much of it. But until you've done that scope and proved that there's nothing else going on, rectal bleeding also should never just be attributed to hemorrhoids and not worked up further. Other causes, I know kind of perseverated about those causes of blood loss, but other things that can cause blood loss, iron deficiency as GU losses, it's very uncommon, but I'll typically just check a UA to make sure there isn't any microscopic blood loss going on. Decreased absorption is also a concern. This is particularly in any gastric surgery patients, including those bypass patients, anybody with celiac disease that's causing impairment of that duodenal absorption, H. pylori infection or atrophic gastritis are impacting that acidification of iron and subsequent absorption. Pregnancy, as we mentioned, there's 1 gram of loss per pregnancy. And so you can see somebody who's multiparous, especially in a short time, may not be able to keep up with that. And so in those patients, they can become iron deficient. Hemolysis, if it's chronic and ongoing for a really long time, can also cause iron deficiency. So it's just something to keep in mind. And then decreased intake, whether that's through a really restricted diet or just lack of nutrients from the average diet of that area. I did think it was interesting that in hemodialysis patients that they lose about 2 grams of iron per year. So these patients, we oftentimes see them getting erythrocyte stimulating agents, and often that's done in conjunction with iron repletion because we know they're going to go through a lot of that iron just from being on the dialysis machine. So now we've identified our patient's iron deficient. We're doing a fabulous workup to find out why. And then how do we go about fixing that iron deficiency? We can either do oral or IV repletion, and there's pros and cons to both. For oral repletion, it's significantly cheaper. It's much easier for patients to access and requires less time in the clinic. So those are all really great upsides. That being said, some patients do have significant side effects with it, particularly GI ones. Some people have some stomach upset, nausea, constipation, dark stools, which really isn't a problem, but it does bother some patients. And as far as iron formulations to try to improve those symptoms, I haven't found anything to consistently be better for patients. I do see some patients who really prefer the liquid formulations and feel like those go down better with less GI symptoms. There are so many formulations available, and there's really not good data to prefer one over the other. We do generally recommend the equivalent of 65 milligrams of elemental iron, and we recommend every other day dosing. Traditionally, we've done 3 times a day in the past. Even when I was a med student and resident, I remember recommending that. But since there's been studies that have shown that absorption is really not improved with that, and it's actually negatively impacted, and we decrease the GI absorption when we overload it with iron like that. So every other day really is best. Unfortunately, with oral iron repletion, it is slow, so it can take many months to get to full iron repletion. For that reason, usually by the time they're seeing me, I'm thinking about using IV iron because either they've been intolerant or we just don't have the time to wait. It is unfortunately much more expensive. It is better if you have really severe iron deficiency, again, that you want to improve very quickly, or absorptive issues where we've tried oral and it's just not getting absorbed well enough because of ongoing either bypass issues that are impacting absorption, or if there's celiac or some other condition like that. I also preferentially use IV iron in my pregnant patients. It's safe to be used in the 2nd and 3rd trimesters. It's contraindicated in the 1st, but usually we want to be able to provide both our female patient with support as well as their fetus with support for their developing hematopoietic system. So in those patients, I prefer to use IV to really get that to them quickly. I also use it in my oncology patients who are receiving anti-neoplastic therapy because I want to be able to support those red blood cell counts while they're going through treatment. And so I use IV in those patients as well. The next anemia we'll talk about is B12 and folate deficiencies. These are some of those classically macrocytic deficiencies. And I have a picture here of hypersegmented neutrophils, so that if you're getting a board question, it tends to be this picture here for a macrocytic anemia caused by either B12 or folate deficiency. B12 deficiency can occur slowly over years. Folate can be a little bit more quickly as far as that chronicity of anemias. And we're usually checking both B12 and folate acid levels to identify and diagnose these. Those numbers, just like we said with those iron tests, they aren't perfect. And so if we get a normal B12 level, but we're really either it's borderline or we really have a high level of suspicion that this is B12 deficiency, checking additional tests with the methylmalonic acid and homocysteine can be helpful. Methylmalonic acid should be elevated in the setting of B12 deficiency, regardless of what the homocysteine looks like. And homocysteine is typically elevated with folate deficiencies. If the MMA is normal, then there usually is not a concomitant B12 deficiency. Causes, some of them have some overlap with iron deficiency causes. So things that are nutritional deficiencies, especially our patients who are vegan or vegetarian, usually B12, it comes from animal sources most commonly. So if we're limiting those animal sources of B12, these patients have to make a conscious effort to replete that in their diets. And if they aren't able to keep up, they can become deficient. Patients with pernicious anemia create autoantibodies to intrinsic factor, which can impact absorption of B12. These patients may also have autoantibodies to antiparietal cells and have concomitant iron deficiency as well. So there can be some overlap. And really anything that's impacting that stomach, small bowel, for example, celiac disease, as we mentioned, gastric surgeries can impact the absorption of all of these nutrients. And then in pregnancy, we can sometimes see folate deficiencies. It's much less common, at least in this country, where most patients are taking folate supplementation throughout their pregnancy with their prenatals, and our food is very fortified in folate, so it's much less common to see here. But in other countries where maybe that access is not there, we may see that in pregnancy as well. As far as symptoms, just like with anemia related to iron deficiency, anemia symptoms are going to be present, but there can also be symptoms that are unique to B12 deficiency. Neurocognitive symptoms are the ones we typically think of, and they can be really serious and can be permanent side effects of B12 deficiency if we don't replete quickly. And these can be present even in the absence of anemia. So just like we said, Pica can be there, and some of those effects of iron deficiency can be present without anemia. Same goes for B12. Those neurocognitive symptoms include paresthesias, ataxia, cognitive slowing, abnormal deep tendon and reflexes, among others. As far as repletion, we've got a lot of options. Typically for folate, we're able to get adequate repletion through an oral route. Even if it's an issue of absorption, usually we can ramp that up and manage to get people to normal levels. For B12, we have a variety of options, usually either oral or IM or sub-Q is being used where I see. As we're using IV, it's going to be typically if we have those neuropsychiatric symptoms that we really need to intervene on very quickly, or again, those pregnant patients where we really just want to get them replete. And IM would give you the same kind of absorption as the IV, and typically I've seen that preferentially used. For folate, I do usually replete folate alongside B12, even if the labs look normal for B12 initially. Sometimes as the body incorporates folate and B12 into making more red blood cells while you're doing the folate replacement, you can actually unmask a B12 deficiency, and B12 replacement is pretty cheap and easy to obtain, really low side effect risk. So usually I'll do the two in conjunction with each other just to avoid the development of those neuropsychiatric symptoms. For dosing of folate, it's usually 1 milligram per day, but you can go up to 5 milligram per day if needed, especially for those patients with poor absorption. For B12, it's again the same milligram. For some reason, we choose to write it as 1,000 micrograms weekly. And so this is a weekly versus the other one being a daily dosing. And then once they're normalized, we change to monthly. And the dosing is the same regardless of the route of administration. Typically, anemia should improve within a few weeks and normalize within a few months when we're doing either B12 or folate repletion. And we may need long-term repletion in those patients who have ongoing losses or ongoing absorptive issues. Next anemia that we'll touch on is the anemia of chronic inflammation. This used to be called anemia of chronic disease. So we see both as kind of names for it, depending on what you're reading. This can happen in any inflammatory condition, can be things like malignancy, autoimmune disease, rheumatologic disorders, inflammatory bowel disease. We can see a unique mechanism in CKD, things like CHF, COPD, any of these kinds of things can cause that chronic inflammation setting and cause anemia. The proposed mechanism by which this happens is that inflammation causes these inflammatory cytokines to increase, and then they cause an increase in hepcidin. Hepcidin causes degradation of ferroportin and eventually causes decreased iron absorption, as well as decreased macrophage release of iron. This causes iron to become trapped in the reticuloendothelial system. So even though many times these patients have adequate iron stores, they're just not able to tap into those and use them. Another mechanism that's less understood is that perhaps the cytokines that are released by chronic inflammation may decrease erythropoietin production. There's less data on this end, but another proposed mechanism. This definitely does have a role in the setting of CKD, because we know with chronic kidney disease, erythropoietin production is definitely decreased in many of these patients, and that's why erythrocyte stimulating agents are often used. This is a setting where we mentioned we always want to keep in mind the iron stores, because we can't tell the bone marrow to make blood cells if it doesn't have adequate product with which to make those red blood cells. So we oftentimes do those in conjunction with each other. With anemia of chronic inflammation, labs that we can check to try to help us confirm that. The ESR and CRP are both markers of inflammation, and these will be elevated in the setting of anemia of chronic inflammation. Erythropoietin levels can be low or normal. They tend not to be high. Iron studies at a first glance can be suggestive of iron deficiency, but when we look at that ferritin, the ferritin is going to be elevated in most settings due to being trapped in that reticuloendothelial system. Also, ferritin, we said, goes up as an acute phase reactant, so we have really two reasons why that number would be elevated. The serum iron is often low because the amount that's accessible is low. And then the iron binding capacity is the other difference. That's usually going to be elevated in the setting of iron deficiency, because your body's trying to grab onto more of that iron, absorb more iron, but it's not going to be trying to do that in the setting of anemia of chronic inflammation, because it recognizes it has too much, it just can't get access to it. Most important in the treatment of anemia of chronic inflammation is just identifying what is that underlying illness and how do we treat it. And as I mentioned, sometimes there's an overlap with iron deficiency that can be really tricky to sort out, and certainly would be a good time to get a hematologist involved if you're having trouble interpreting those labs and seeing what the true iron status is. The last anemia we'll talk about are hemolytic anemias. They do have a broad range of causes. They can be hereditary, things like G6PD deficiency, hereditary spherocytosis. There can be acquired causes for hemolytic anemias, the dreaded thrombotic microangiopathies like TTP, HUS, atypical HUS. There can be infectious causes like malaria and babesiosis. Drug-induced hemolytic anemia can either be acquired, or there can be an autoimmune component to that as well. Mechanical heart valves can cause shearing and destruction of red blood cells as well. Paroxysmal nocturnal hematuria, and then transfusion reactions. Usually that one is pretty obvious, because you know you've recently transfused a patient, and then they would have that hemolytic process. And then the autoimmune, and we'll talk more about all of these. As far as labs, they're often normocytic, but as I mentioned, if there's severe reticulocytosis, we may see some macrocytosis as well. If the bone marrow has adequate building blocks, so adequate nutrients, and is functioning appropriately, reticulocyte count should be increased in hemolytic anemia. We'll see an increased LDH and indirect bilirubin too as breakdown products of those red blood cells. And the haptoglobin will be low. Low, and especially an undetectable haptoglobin, is pretty specific for hemolytic anemias. Haptoglobin is a molecule that binds free hemoglobin. And the hemoglobin is released from those red blood cells. As it binds the haptoglobin, the amount of free haptoglobin that we're measuring is going to be low. So that's how that number becomes decreased. And then, of course, the peripheral smear is going to be really important to look at as well, because we love that. And it can give you some clues as to what might be that underlying etiology. This is a picture of Heinz bodies and bite cells that can occur in G6PD deficiency on that peripheral smear. These little black kind of dots that you're seeing with the red arrow show those Heinz bodies. And as those red blood cells pass through the spleen, there could be some phagocytosis of those areas with the abnormality causing those bite cells that we're pointing out with the black arrow. Spherocytes are another thing that we can see on the peripheral smear very commonly in hemolytic anemias. These are smaller than the average red blood cell in size, and they are kind of solid looking because they are shaped like a ball. So there's none of that area of central pallor. This occurs as the red blood cells pass through the spleen and are phagocytized, and that changes the shape because we're removing more of the surface of that red blood cell and increasing the cytoplasmic to surface area ratio. And we can see the spherocytosis both in hereditary spherocytosis as well as just in all hemolytic anemias. The worst finding to see when you're looking at that peripheral smear is going to be those schistocytes. So these are sheared red blood cells. This happens in small blood vessels, can also happen in the setting of those mechanical valves, although that's, again, a little bit more obvious. You're going to know that someone has a mechanical valve or that has been on a bypass machine. But if you're seeing it outside of that setting, then we're really worried about those hematologic emergencies, things like TTP, HUS, atypical HUS. In these settings, you really want to be at a center that can do plasma exchange and to do some of the testing to confirm those diagnoses. Another test that's very important in hemolytic anemias is the Coombs test, or the direct antibody test. This confirms the autoimmune etiology of hemolytic anemia if it is positive. The test takes washed red blood cells from the patient that are incubated with anti-red blood cell antibodies. If their red blood cells from the patient become coated with these antibodies, it'll agglutinate and kind of clump up, and that test will be positive. Usually we're testing for IgG and complement antibodies, and if these are positive, we call it a warm autoimmune hemolytic anemia. If IgM antibodies or complement are positive and it agglutinates at colder temperatures, so lower than body temperature, then it's a cold autoimmune hemolytic anemia. For warm autoimmune hemolytic anemias, there's oftentimes an underlying etiology for that, so it is important to evaluate for that at the same time as treating the hemolytic anemia. In about half of patients, we'll be able to identify a cause. It's important to note as well, though, that sometimes these causes aren't initially apparent and can become something that develops over months to years after the initial diagnosis of the hemolytic anemia. Things that can cause it include hematologic malignancies, CLL, lymphomas are particularly culprits. Connective tissue diseases like lupus or other autoimmune diseases can be associated with this. And in today's day and age, COVID-19 also can cause these hemolytic anemias. In all of these settings, just having the autoimmune hemolytic anemia does increase the risk of thromboembolic side effects. So these patients should receive VTE prophylaxis. And if there's any symptoms or concerns for venous thromboembolism, we should be quick to work that up. As far as treatment, really important thing to note is if these patients are very symptomatic, they need to be transfused. Because of the autoantibodies, it's oftentimes difficult to find cross-match compatible blood. So sometimes clinicians will hold off until they can find a compatible unit of blood, but it's really going to be hard to find one just because of the way those antibodies work. It's not something that's necessarily going to impact them in vivo. So it is important to just find ABO compatible blood and transfuse them. The next step is steroids. Usually we can get at least a temporary effect, and for some patients more of a long-term effect. About 20 or 30% of patients will have improvement with glucocorticoids long-term. Usually we dose this at 1 milligram per kilogram of prednisone daily, so pretty high doses. And typically once hemoglobin and hemolysis markers have stabilized, then we begin a really long, slow taper. It's recommended that this take 6 months or longer. So this is a long time for steroid exposure for patients. So usually we do consider PJP prophylaxis as well during this setting. Rituximab, I usually add this on because it does improve the outcomes and long-term responses that are seen. The combination of rituximab with glucocorticoids gives you about a 2/3 response that's maintained at 2 years, and hopefully can limit the amount of time that patients are on glucocorticoids so they don't have to do that whole 6 months of being on it and be at that higher risk. You should see a response with rituximab within a few weeks. I usually tell my patients about 4 weeks or so to expect a response. So that's time that they're probably going to be on those steroids. Rituximab does cause reactivation of some viral infections, including HIV and hepatitis B and C. I usually screen my patients for all 3 of those before we start rituximab, and it can also cause TB reactivation. So if there's a patient that you suspect that, or if patients live in an area where TB is endemic, it's important to screen for that as well before you start rituximab. Other treatments, IVIG is often used. This is administered either as for daily doses or a one-time dose, and this is really more of a temporizing measure. So what the IVIG does is it goes into the spleen and blocks the macrophages FC receptors so that the spleen doesn't cause phagocytosis and destruction of red blood cells in that spleen, and it kind of overwhelms the spleen's ability to do that. It is temporizing because as soon as those antibodies come off and degrade, then the spleen goes back to chewing up those red blood cells. But it does allow us to buy some time. Let's say if a patient didn't respond to steroids and we're waiting to try to go on to that next therapy. By that same thought process, if we say the spleen is chewing these up, sometimes taking the spleen is a good answer too. So we get response rates of about 75% with splenectomy. It is more invasive, and for that reason, I usually like to try the rituximab first before we go to surgery. But nowadays, we have amazing laparoscopic techniques that are pretty minimally invasive, so it is also a good option for a patient who doesn't want a medication route. If you're at all considering splenectomy, it's important to vaccinate patients against encapsulated organisms. Patients can have overwhelming infections with Haemophilus, pneumococcus, meningococcus, and getting those vaccinations on board at least 2 weeks prior, if possible, is helpful. Other long-term risks, by a mechanism we don't really understand, there's an increased thrombotic risk as well as an increased secondary malignancy risk long-term for these patients. It's small, but something to be aware of. There are other immunosuppressant and cytotoxic agents we can use in further line settings if those initial treatments don't work. I won't talk any more about those. There are some supportive medications that are important for hemolytic anemias. There is really rapid red blood cell turnover, and as a result of that, folic acid is used up quite a bit, and these patients can become deficient in folic acid. I just kind of automatically put all hemolytic anemia patients on 1 milligram daily folate to support that. And then we mentioned previously that if these patients have long-term hemolysis for months and sometimes years, they can develop iron deficiency. So I do periodically check those or chronic hemolytic anemia patients for iron deficiency as well. Cold autoimmune hemolytic anemia, we'll just briefly touch on. The labs are going to look very similar to the warm autoimmune hemolytic anemia, but the direct antibody test will be positive for complement, IgM, and cold agglutinins. These patients can have Raynaud symptoms that are a little more specific to the cold version. This is going to occur on the hands and feet, but can also occur in nose, ears, even around the mouth, and can be really pretty prominent. This is also associated with underlying malignancies, even more so than the warm version. So really important to check for those when you diagnose cold autoimmune hemolytic anemia. So with that, I'll just conclude the talk with a few things that I want to make sure you guys take home. So if you remember nothing else from this talk, I want you to remember that hemoglobin is the most important lab test in that CBC for measuring oxygen carrying capacity and to measure the degree of anemia a patient has. Iron deficiency is the most common cause of anemia throughout the world, and iron deficiency is never normal. We need to find the underlying source of it and address that. And as far as measuring iron deficiency, that ferritin is going to be your most important test. So thank you all for your attention. I'll go ahead and open it up for questions. And here's just a picture of where I live for you guys and my contact as well, in case anybody needs to reach out down the road.
Awesome. Thank you so much. Wow, I'm jealous. I want to live there. That looks so pretty. Um, if anyone has any questions, feel free to use the Q&A box at the bottom of your screen. Our friends in Cameroon, you're also welcome to walk up to the computer as you normally do and ask the questions. We'll just give it a few minutes, see if anybody is thinking and trying to formulate.
Absolutely.
Okay, we have someone that raised their hand. So I will unmute you if you just raised your hand, Ariba, just so you know you'll be able to talk then.
Yes, thank you very much for this nice presentation. I'm a resident in internal medicine at Makerere University, Mulago, Kampala. So I wanted to know how long, according to your treatment experience, do you put patients with vitamin B12 deficiency on treatment? And are there some long-term goals that you would target? And then secondly, upon development of neuropsychiatric manifestations and successful treatment, are those symptoms going to resolve, or you would have continuation of those neuropsychiatric symptoms despite success of treatment? Thank you very much.
So yeah, thank you so much for the question. As far as duration of that repletion, we're going to be monitoring them. Usually I do about once a month or so of checking B12 levels, and specifically that methylmalonic acid, so I can really see what the stores are doing. And then once those have kind of normalized and we've seen a couple months of normal levels, depending on the cause, you may be able to back off. So if it was just a nutritional issue and you can get them to change their diet or be able to add an oral supplement to maintain that, you might be able to get rid of more of those more aggressive IV or sub-Q repletion strategies. But a patient, maybe who's had a gastric bypass, some of these patients are on it for the rest of their lives just because they can't absorb it orally. For those patients, usually I don't have to keep doing the monthly monitoring. We can do every couple months, maybe even every 6 months, because they get just on a maintenance routine with that. I have to say, I have not seen anybody with severe enough B12 deficiency to have neuropsychiatric symptoms. So I have no personal experience to see, how much they get better with repletion. I think traditionally, like reading things, that they should get some improvement if you've caught it early enough, but some of those can be more long-term. I think where we are, a lot of times neurology ends up managing those more than hematology does. So I just don't have as much personal exposure to that.
Hello. Hello, I'm from Cameroon. Yes. My question is about pure red cell aphasia. Like, how common is it? Like, how common? Because how common is it in your experience? And then also about like adrenal disorders and thyroid disorders. Sometimes they present with anemia. So how often should you check for secondary causes, and what's the mechanism of the anemia?
So again, I don't see too much of those secondary causes. Occasionally, I'll find a hypothyroidism or hypotestosteronism that's causing that. I don't see too much of that. I actually see more of the other side, where sometimes we'll see patients on testosterone supplementation who come to see me for polycythemia. That's a pretty common once a month or so thing that I'll see. So I see the other end actually a little bit more. I don't know the kind of that basic granular details of why that causes it, especially for the hypothyroidism, but we do know that those hormones with testosterone do cause an increase in production of red blood cells. So that is a pretty direct cause, and we know that that can cause polycythemia if you have too much, and then if you don't have enough testosterone, definitely can cause some or some anemia.
Okay, we have 2 questions in the Q&A. Feel free to open it and read it along with me if you want. So the first one is if there are any clinical implications to checking the serum erythropoietin level.
I think it's a helpful test to check, especially if you have some CKD, to see if those numbers are low. You definitely can add an erythrocyte stimulating agent with caution, because we don't want to overshoot either. Typically, if we're adding those ESAs for patients, we're shooting for about a hemoglobin of 10 or lower. We do know that cardiovascular risk can be increased if we shoot above that. So that could be, I guess, a negative implication of checking that test is sometimes people will just start them on an ESA and not really monitor that much, and we may actually be doing our patients more harm than good if we're doing that. Other than that, I don't think there's any negative side to just checking that test and knowing what we're dealing with, because it is a pretty easy intervention to make sure we're adding that for patients that do have low levels.
And then the second question is if there are any hazards to having higher vitamin B levels.
So there's not. Both the B12 and folate are managed through the kidney. So as long as kidney function's pretty good, we shouldn't get overly high levels. So other vitamins, especially those fat soluble ones that we worry a lot more about over supplementation and side effects, but both with folic acid and B12, we really don't worry about over supplementing. It's just that they're able to urinate that out and the kidneys take care of it. So we don't really worry about those. Those are water soluble and they're fine.
Okay, awesome. Any other questions from anyone?
No more questions from Cameroon. Thank you very much, Dr. Sudy, for doing this for us. Thank you.
Thank you guys so much for coming.
Awesome. Well, I don't see any more questions in the Q&A, so I think we can wrap it up. Thank you so much for coming, giving this talk. Thank you everyone who attended. We will have this recording up on our website, as we do with all our grand rounds, so feel free to check that out. Thank you, everyone.